Well, hello, Michael. It's so good to see you again and to kick off our 5th Health Literacy in Action Conference. I told my dog, Georgia, this morning that we were doing the conference and she gave me a paw high five, so I'm feeling really good and confident. How about you?
Well, I don't have a dog to paw high five with, but I am in fact also doing very well and confident. Thank you. Welcome, everybody. Really happy to have you all here, and welcome to our, as Cynthia says, our 5th annual Health Literacy in Action Conference. We sure wish we could be here in person with you, but this is the next best thing. So thanks, everybody. If you want to go ahead and take your virtual seats, I think we're going to go ahead and get started. If we could get the next slide, we'll take care of a couple of quick housekeeping tips first. So everybody is going to be muted during the presentations, obviously with the exception of the speakers. At the end of each session, there will be a Q&A session. So if you have questions, please type them in the questions box at the Q&A box at the bottom of your screen. If you want to just make a comment, hello, glad to see you, that sort of thing, you can type those in the chat box. And then our Twitter handles are at HLiA Conference, at IHA_THE, and at UMD Health Lit, and the hashtag is HLiA Conference. So please, we'd love for you guys to take full advantage of social media and get the message out there. Share any of the things that you're learning, and registration will be open throughout the conference. So if you have colleagues that you want to join who haven't, you can encourage them to go ahead and join. And our next slide, please. If you're having any technical difficulties, you can send an email to info@hlaactionconf.com. You might want to write that one down now, hlaactionconf.com. The presentations will be recorded and they're going to be posted on the conference website, which is where you went to register, hlaactionconf.com, about 2 weeks after the conference. So you can go back and take a look at those. And then please remember to fill out your overall conference evaluation. We really do read those and make changes based upon what we see there. And if you're asking for continuing education credits, you need to submit that overall conference evaluation in order to get your certificate. And the link for that evaluation is going to be sent to everybody Friday at the conclusion of the conference. With that, I'm going to turn it back over to Cynthia for the introduction of the next session. Thank you.
Great. Thank you so much, Michael. So today we're going to open the conference with a very special tribute to someone who has been really central to the Horowitz Center for Health Literacy here at the University of Maryland. And that's my colleague, dear colleague and friend, Dr. Alice M. Horowitz. She is an oral health literacy pioneer. She has a very distinguished career. I think people have been using 50 years, but Alice, I really think it's more like 60-year career when I was thinking about it. But she says, who's counting? So we wanted to take a few minutes and just recognize really the so important contributions that Alice has made to 2 areas, oral health and health literacy. So thank you so much, Alice, for joining us here today.
Thank you, Cynthia, for allowing a few minutes for this time. As I will remind you, you always want to do these kinds of things, and it embarrasses me, but at the same time, you remind me that it's a way to increase literacy, oral health literacy, and health literacy. So I'm all for that. Yes. So next slide, please.
Okay. Well, so Alice, you have been, one of the biggest cheerleaders for Healthy People, and Healthy People has been really central to the growth of health literacy within public health. So you and I have really been working in parallel for the last 20 years, and I'm counting that, by the way. So I thought we might just review for people sort of what that trajectory within Healthy People has been. So in 2010, I was in charge of the health communication chapter, and we had a health literacy objective. And you were, I think, a co-lead on the oral health chapter. Correct. So just say a little bit about how oral health and health literacy sort of came together in this trajectory in Healthy People.
Thanks. Well, because I was very interested in health literacy, and as Cynthia has mentioned, was working with her and with the DHHS group on health literacy, that it
Hey,
was.
acronym, I got to jump in there. DHHS for everybody is the U.S. Department of Health and Human Services. So,
Thank you for that
Okay.
correction. Yes. So, but it was important because I was at the right place at the right time, and was able to first define oral health literacy in the oral health chapter of Healthy People 2010. So remember, that was in 2000 that was published. Okay.
yes, and then we've been working together ever since to keep health literacy and oral health literacy in Healthy People. We did have a health literacy objective in 2010 and 2020. In 2030, it's part of the principles, but it's not its own objective anymore. And I think you and I have really kind of been championing this shift towards focusing on organizational health literacy. So I don't know if you want to say a little bit just about the work that you've been doing over the last 10 or 15 years to bring organizational health literacy to dental practices.
Excuse me. Yes, we have done a modest amount in our state, primarily, and doing evaluations of community dental clinics, mainly federally qualified health centers, to determine just how user-friendly they were in these clinics. And it was incredibly interesting. Of the 32 in the state, 26 volunteered to participate in this. And we found a lot of differences, but a few things. Major thing was looking at printed materials that were, at too high a level, reading level, and also the challenge with having consent forms that were at just outrageously high. And we gave them a revised consent form that they could use to help develop their other consent forms. Out of the 26, 2 of these clinics actually followed up with us for additional information and assistance. So it was and it's ongoing. I would actually like to see medical schools and dental schools, nursing schools, all of these schools actually do health literacy assessments.
Great. Yes, and for those looking to find out about that body of work, Alice and our colleagues have published it in a number of different journals. And so you'd be able to find their process, which included surveys, these organizational assessments. There's a really great body of work there for you all to take a look at. So as I alluded to, you were an early adopter of this notion that there's both personal and organizational health literacy. So I don't know if there's anything else you kind of want to add about that, because one of the things that you are always good at reminding people is that we can't hold patients responsible when we as providers aren't doing our job to communicate clearly.
Absolutely, is critical. And remember, there are fewer healthcare providers than there are in the general public. So it really would mean that we can focus more on healthcare providers if we do this in their pre-doctoral, pre-graduation courses, that if we could get them up to speed in this area, that it would go a long way to increasing health literacy, oral health literacy of everyone, really. And we need to also think about increasing the health literacy of policymakers. And this is critical if we're going to make changes for increasing health literacy. And it's increasing health literacy that is going to decrease disparities.
And I just want to point out that you not only have carried this message nationally, but you carry it globally, that you've traveled the world sharing this information with people. And so you've really provided a great role model for the rest of us. So I just, and this is the part that might embarrass you a little bit, but I do think it's really important to acknowledge that you brought your subject matter expertise in oral health into health literacy and really developed this notion of organizational health literacy. But you've also been doing it for oral health. So I don't know if you want to say a little bit about how you've been trying to change hearts and minds within oral health and really, again, help them recognize that it's not, to use your words, not the dumb old patient's fault. So do you want to
Well,
say a little bit about your oral health, trying to
Sure.
influence the oral health field?
It's very easy, you know, to blame someone else, like patients, for not doing whatever X is. And Cynthia's right. I have said those words. Probably not the wisest choice of words, but the point is that it's really up to us to ensure that as providers, that in fact our patients do understand, or policymakers, whomever. But we can't blame them. We have to have the responsibility for ensuring that what we are trying to explain, that they understand. And that's always been my major interest and what we have tried to do in the state of Maryland. Thank you.
I think, you know, you and I have both been involved with activities at the American Dental Association, which has had a ongoing health literacy committee now for a number of years. And I know you've tried to work with other oral health professional groups and really kind of provided an example about how to do this at a broad level, right? So yes, it's good to reach each provider one-on-one, but there's also a lot of change that can be made when you work through these professional groups as well.
Absolutely. Totally agree.
So last, before we wrap up, I wanted to give you a chance to say a little bit about your passion, which I know is integrating oral health with general health and medical care, because again, to use one of your famous phrases, we're putting the mouth back in the body. So do you want to kind of just provide some closing thoughts about that?
Absolutely. And you know this because we've worked, you know, as far as trying to help patients with diabetes, that it's critical that we can also consider oral health in the mouth, because if an individual has diabetes, they cannot control their A1Cs if they have periodontitis or major gum disease. So these two go hand in hand, and indeed this is a primary time and place that we need to integrate oral and general health, both from providers' perspectives, so that they're on the same wavelength and are educating their patients accordingly.
Great. Well, thank you so much for taking a few minutes to join us today and, you know, reflect on all this really important work to bring oral health and health literacy together. You've been such an important mentor and example to me. So thank you so much. And, you know, congratulations on a career well done.
It's still going on, but thank you.
I know it's not done, but, you know, to this
Thank
point.
you very much. It was very nice of you. Yes, thank you.
All right. Well, that concludes our reflection on health literacy and oral health. And now we're going to transition to the next item on our program. And I'm very happy to welcome one of our community partners here from Maryland. We met her through a project that we're doing in Frederick, Maryland, which is a town in sort of northwestern Maryland, above sort of on the western side of the state. So we're welcoming Maria Herrera from the Spanish-speaking community of Maryland to provide some remarks about her perspective working in the community and health literacy. So thank you, Maria.
Thank you so much. Good morning, everyone. It's a pleasure to be here with all of you. As stated, my name is Maria Herrera. I am the Executive Director of the Spanish-speaking community of Maryland. We have an office in Silver Spring as well as Frederick, Maryland. We are a nonprofit organization that strives for equality and sustainability for international immigrants who suffer in silence so that they can be able to reach and enjoy the social economic level necessary for self-sufficiency. We primarily focus on immigration, employment assistance, support with DV and abuse. We have a wonderful team that we work with, partners, as well as health partners, so that people are aware of what their options are, rental assistance and other resources that we provide. Next slide, please. So access is an essential community service. I wanted to share a little bit about SSMS approach to promoting self-sufficiency and meaningful access to critical information about rights, services, and healthcare. And I wanted to share a little bit about why this is so important. But before I move on to the next slide, I want to give a heartfelt thank you to all the medical personnel who put their lives on the line every day to help others. Next slide, please. Before I start, I wanted to give a little bit of facts, US facts, in terms of the population that we serve. As you can see by this chart, I know it's a little bit difficult to read because it's a little bit small, but you can see right here that in 2021, the population, the Hispanic population grew for 2.9% in the state of Maryland. And you can see some other demographics that are shown here in order to understand better why I'm talking about access for the immigrant community. Next slide, please. A little more statistics. 51% of total US population growth between 2010 and 2020 comes from the Hispanic or Latino population. Although we do serve the immigrant community, the vast majority of our clients are Latino. Our Hispanic and Latino children from 2010 to 2020 grew to 25.7%. Many of you may know this or not, but Maryland is now the most diverse state on the East Coast. And Howard and Frederick counties had the highest percentage growth, which is 16%. Now Maryland has a white population of about 47% as compared to 55% in 2010, which makes Maryland a wonderful, diverse state. Next slide, please. So when we talk about access to resources, one of the things that we need to understand first is the challenges that immigrants face when they come to the United States. I'm an immigrant. I came to this country when I was in second grade. I came from Cuba and I came as a refugee. I came with my mom, who did not know how to read or write, and my sister, who was 17, who could not attend school because she needed to work to support us. So I am one of those people that have come to the United States and understand the challenges that one faces. One of the challenges that is dear heart to me is the fear and trust issue. There's a lot of people that come and just do not know what to say or what to tell. They're fearful for their status. They're fearful for what people may consider them to be. So there's a lot of anxiety that takes place. Also, there's a lot of loss of income for some, inability to get any government relief because of their legal status. They tend to be the people who get lower wages. There's big disparities in this area. There's the lack of health insurance and fringe benefits due to the positions they hold, which sometimes may be in a hotel, in a restaurant, and they do not have the same benefits that a lot of us are privy to. We see a lot of school dropouts because everyone must work when, as we all know, things are getting more expensive on a daily basis. And sometimes when you're working in a minimum wage rate, it is very difficult to be able to achieve or be able to get your everyday necessities. So that means that everyone is expected to work. Employment instability. A lot of times people are let go just because they're sick for a day. They tend not to be considered in the same way that others are. Lack of medical attention. A lot of them become self-medicated. They do not see medical needs as important to them. They think that by drinking a special tea or by doing certain things, they can heal. They also have multi-family living arrangements, which are very unhealthy situations. I have seen families in a 2-bedroom apartment where 5 or 6 families live in a 1-bedroom apartment. I have seen dining rooms being rented out at $700 to $800 for that family. So it becomes a very unhealthy situation. So all this derives to mental health issues. The trauma they've experienced, the anxiety, the depression, which then in turn turns into alcohol, and the isolated fear that they feel every day. Next slide, please. So I wanted to share a little bit of the strategies that the Spanish-speaking community tries to focus on in order to relieve some of these anxieties that we see every day. Personal interactions and relationship building is a must. Cultural sensitivity discussions is also a must. Sometimes people interpret things differently, and just because we're accustomed to doing it one way does not mean that our clients are going to receive it in the same fashion. So it is important for us to understand that cultural sensitivity is a must if we want to help families. Time up front spent with these families is crucial. As we all know, first-time impressions are everlasting impressions, and a lot of us can make impressions in 15 seconds by having a conversation with someone. Sometimes we have to have the broken record routine so that people can really listen to what we're trying to tell them. There needs to be a lot of hand-holding. We have to understand that when we deal with immigrants, sometimes this is a journey and not a sprint. It takes time, it takes confidence, it takes trust in order for us to get to the goal. Breaking down information, paying attention to your audience. There's a lot of times that we speak in terms that people really do not understand us. So we need to be really careful and pay attention to who our audience is and how we're going to address our audience. Sort of the knowledge-based approach about your patient, understanding how you communicate that information, which also derives from the educational level when providing the information. Community forums, working with health professionals and partners to educate and answer questions. You know, it takes the village for all of us to work together to be able to meet the goal. Engaging people of trust to speak about healthcare, sharing stories about health outcomes also helps as we work together to become successful and help families. Next slide, please. So what does this all mean? Well, the outcomes is what we're looking for. You know, we're looking for trustworthy relationships between providers and clients, right? We're looking for patients willing to open up regarding their health issues or other services that they need. It is important that we have these honest and truthful conversations so that we also understand what their other needs are. Because as we all know, mental health as well as other health conditions are derived from stressful situations at times. So as the more open we are and the better relationship that we build, the stronger we are going to be as a community. Also, there's preventive versus reactive measures. The Hispanic community, I can speak for my own family, tends to be more reactive to healthcare or other things instead of preventive. And that's because we tend to say, oh, it's okay. No, we're not going to do this. So it's going to go away. So being able to talk about being preventive versus reactive is very important. Word does get around the neighborhood. So as we educate people and we work with people, they will also become our cheerleaders for letting others know what type of resources are available to them. Saving lives and fast intervention. Well, there's a lot of people we know about diabetes and other health conditions that take people's lives. And sometimes by the time they end up at the hospital, they already are in kidney failure or other situations that are very, very difficult. I am not a health professional, but I do work with families that end up in this situation. So consequently, again, this introduction, this relationship, this trustworthy relationship is what helps us move the needle. Another concern, big concern, is the healthcare cost savings. So if we can get people to the hospital, we can get people resources in other areas of employment or things of that nature. We are reducing our costs because we are mitigating situations before they come to a situation when things may be way too late or the cost would be more exorbitant than having handled the situation prior to that. I think with all these outcomes and these challenges, if we can kind of meet in the middle, we will all have a win-win situation. Next slide, please. So what are the strategies? You know, one of the things that I think if we all self-evaluate that we tend not to do is evaluate ourselves. And that is because of our stress level, because of the work that we have. We sometimes can't find the time to really do an assessment as to how we're doing or how we're working with the people that we work with. So I took the liberty to put some questions out there that I try to do now that I did before, to make myself a better advocate for the community that I serve. Are you devoting enough time to understand your patient's needs or anxieties? Removing your professional hat, what would you expect from your own doctor at your medical appointments? Do you handle your patients in the same manner that you expect your providers to address your health needs? How culturally sensitive are you when working with your patients? Have you taken a cultural sensitivity class? Are you a pamphlet giver or an advocate for the patient? A lot of times we tend to think that just handing people pamphlets is the answer to a lot of questions, but a lot of people, in special cultural situations, people tend not to relate in that fashion. So having a one-on-one conversation can be the difference between someone going to the doctor, building a relationship, or someone not coming back. What type of feedback do you ask your patients in order to improve their overall experience? Is diversity and cultural sensitivity training conducted at your office? Is your staff, the staff that you has face-to-face with your practice on a daily basis? Do you establish relationship with other organizations or resources to help your patients? For example, this organization and other organizations sort of, I like to call us as an extension of a lot of the healthcare, employment, things of that nature, that we are able to help families navigate these situations. Domestic violence is another one. Not necessarily can a health professional handle all of these their clinic or their organization, but there are organizations such as ours that extend beyond your organization and are able to provide additional services or guidance to people in need. And I guess the big question that I always have to everyone is, why did you select your profession? And I would like to say that I selected my profession because I am passionate about helping people and making a difference in someone's lives. Someone, when I came to this country, made a big difference in my life. There were a lot of people that I have that helped me, guided me, and provided some invaluable information that I would forever be grateful for. Next slide, please. So I would like to end this presentation with, again, they may forget your name, but they will never forget how you made them feel. It is a beautiful thing when a career and a passion come together. So that concludes my presentation. If there are any questions.
Great, thank you so much, Maria. I think that's such an important reminder about the first impressions. We sort of forget about that. And you've given us a new phrase, are you a pamphlet giver? So I think we can set that as one of our expectations, is that we should not be the pamphlet givers. We should be the advocates of the world. So thank you for that.
So there's a question about, I think that just popped up, about how do I get our funding? So we are not a healthcare provider. So what we do is we team up with other healthcare providers, and we actually, people come to us and may say, I haven't been to the doctor in 3 years. Oh, I don't know where to go to seek medical assistance. So what we do is we give them, and sometimes we actually take them, we help them fill out their application. We contact the partners that we've teamed up with at dental clinics, at the health department, at hospitals, and then we help them navigate those challenges. Hope I answered that question properly.
Great. Well, thank you so much for joining us and kicking us off with that, very real world perspective, not only on the challenges, but giving us some very thoughtful rubrics to think about our way forward. So thank you so much for starting us off with such a great set of guidance.
Thank you very much for having me.
So now we're going to turn to our opening plenary session, and I am very excited to welcome two good colleagues, people who have been in the trenches fighting the good fight for a long time, and I'm really looking forward to this conversation, because I think this represents a new way forward for thinking about health literacy from a policy perspective. So this session is called A Policy Approach to Health Literacy Impact, and I am joined today by Lenny Preston, a longtime consumer advocate in the state of Maryland, and Delegate Jocelyn Pena-Melnick, who is also the chair of the Health and Government Operations Committee in the Maryland House of Delegates, and the sponsor of the bill that became law that we're going to be discussing today. So welcome, ladies. I am so pleased to have you here and have this conversation. So we're going to start off with Lenny kind of giving us that perspective from the roots of this Consumer Health Information Hub, which was the bill that we're going to be talking about, the bill that became law in the most recent legislative session. But Lenny is going to give us that perspective from where did this all start from and how did we get to 2022 and Chairman Pena-Melnick being willing to tackle this as an issue. So Lenny.
Great. Well, thank you so much for being here. It's just a real privilege. And I was excited to see how many people are coming from across the country. And I respect those out in California who got up really early. So we'll try to make this interesting and engaging. So I'm here to provide some historical context for the creation of Maryland's Consumer Health Information Hub, and also talk about the advocate's role. And I'm now not associated with any organization, so I'll try not to say anything too incendiary, which I'm known to do sometimes. But let me remind you first about the long arc of history, to paraphrase Martin Luther King. So the arc for getting to the hub, from my perspective, took more than 15 years, not Alice's 50 or so. And I think it required all of what I think of as the advocate's 5 Ps. So you'll see these work their way through my conversation today. So passion for the work that you do, purpose, because everything you do has to be grounded in your mission, partners, because there's no way you're going to do this alone, patience, because we all know that Rome wasn't built in a day, and persistence, so you have to be in every single room where the action happens, whether it's that sausage making or the policy making. And my perspective comes from leading a health policy consumer advocacy organization that was founded in 2006, focused then on getting healthcare for everybody in Maryland and moving into the arena of health equity, which became its primary focus. From the very beginning in 2006, there was discussion about the importance of health literacy, but it really didn't come into focus until passage of the Patient Protection and Affordable Care Act in 2020, in particular because in Maryland, we took a very aggressive approach to implementation of the ACA, and that included expanding Medicaid and setting up our own state-based initiative, exchange. And throughout that process, the health literacy became increasingly important as we understood that it had to cover health insurance literacy. And so starting in 2010, there were endless number of newly formed committees to write the legislation and create the policy. So what we did was we made sure that we were in every room. Sometimes we had to come in through the back door. We sat ourselves down at every table, even when we didn't have an invitation. And when we got to the table, we spoke up and we laid out always, not only the problem, but we brought a solution to the table. So because as probably many of you know, when legislators or policymakers see advocates coming in the room, they think, oh my God, these people are going to be trouble. So my philosophy is to glom onto what John Lewis said, that you have to make good trouble. And to make good trouble, you have to come in with the solutions. So one of the first problems, as I said, that we identified with the ACA was the fact that you had eligible people coming in now to buy insurance and they had no idea what insurance was or how to pick out, you know, what would suit the needs of themselves and their families. So in other words, they had low health literacy levels. So lots of entities in Maryland hopped on the bandwagon to produce materials, but this will sound familiar. There was no organized, statewide, comprehensive, cohesive approach to messaging and communication. So sounds a lot like COVID. In the 8 years since we opened the exchange, Maryland's done a good job of getting good information up on the website and using their regional navigators. So now one of our big problems, and I think this is the importance of the hub, is that people now have plastic cards and they don't know how to use them, whether it's to get preventive care or whether it's to deal with an illness of some sort. So here's where I think everybody should be thinking about this, what's going to be happening with the hub and the value of it. But in Maryland, we have a defining issue that frames all of the work that we're going to be doing. And that is Maryland's unique hospital rate setting system. We have a waiver, a Medicare waiver from CMS that set up what's called our total cost of care model. So in Maryland, I would argue, and Chairman Pena-Melnick might disagree with me, I don't know, but to me, every policy, everything that we do in Maryland around healthcare and the health system goes through this lens of how it's going to impact our total cost of care model. And so for you in other states to think about what is that defining piece of the health reform prospect that you have that you can leverage in some way to get health literacy on the table. So, as an advocate, again, with the total cost of care model and getting health literacy on the table, there are endless number of committees with the total cost of care model. And we made sure we were at all those tables. And your job is at every single table you're at, say the words health literacy over and over and over again, because it's going to take repetition. And I like to say, you know, forget carpe diem, because that's a wasted day. You really need to think about occasionem carpe, seize the opportunity. So that's your, if you get nothing else from my discussion today, I hope you'll take that away from you. So to those of us who are here on this webinar, the value of health literacy is important. I mean, Alice did a great job of explaining why literate consumers are important, but it's been a really hard sell in Maryland, and I'm sure it's been a hard sell elsewhere. So how did we, after all this time, actually get a law that set up the Maryland Consumer Health Information Hub? And I think there are a number of factors at work. One is the value of the Horowitz Center at the University of Maryland. There can be no doubt about this wouldn't have happened without them and without the leadership of Cynthia Bauer and Alice Horowitz. The other thing is you've got to have a chairman, Jocelyn Pena-Melnick, sitting at your table. I don't know how, I hope you all have her. Maybe if you don't, maybe you can clone her. I don't know, but you need somebody who understands health literacy and who knows how to work the system. And in Maryland, another factor in making all of this work too, or making it possible, was the total cost of care model and having to meet the metrics. But another big piece of this, and I think really the most important one, is that there's a much greater understanding of the links between racism and injustice in the healthcare system and the health disparities that come from that. And I think that you've got the national movement that followed the deaths of Freddie Gray, George Floyd, and way too many others. You have COVID, which completely exposed the disparities that we're working with. In Maryland, again, thanks to Chairman Pena-Melnick, we now have a commission on health equity. She sponsored that bill, and it's in law and in place, and I work on the policy end for that commission. And we've actually put health literacy in 3 domains in their work, which I hope will make it into the final report to the legislature. But so we put health literacy in the domain of the healthcare system, community and consumer engagement, and also in education. So again, think about seizing that opportunity. We're going to use the opportunity of the commission to get more discussion about health literacy. So let me just wrap up with a personal experience that really made the importance of health literacy come home to me. Unfortunately, it was a cancer diagnosis, but I'm super great. So, but what it did was it really, for me, laid bare the very poor job that we do to arm consumers with the information and resources they need to address their health, whether it's preventive care or whether it's something like a cancer diagnosis. So here are a few things I learned, my takeaways. I was only able to navigate the impenetrable, truly impenetrable healthcare system because I had financial and other resources so I could get to the top docs. And because I'd worked on health policy in Maryland for 15 years, I actually knew the people to call if I couldn't get what I wanted. And that is such an unfair system that there's the passion, right, for me, that we have to do something about it. For me, another thing I learned was the challenges of identifying, coordinating, and communicating with my medical team. A challenge identifying which doctors have privileges at which hospitals and what does that actually mean to you. And setting up my patient portal. I mean, I'm pretty IT savvy. I could do it, but my husband needed help. He had to call the tech team. And then you know what? You get in your patient portal and you get a lab report before your doctor calls you to tell you what your diagnosis is. This is not pretty. And if you don't have tools to understand what that's said on that portal, you're in trouble. And imagine trying to determine what medication to take when 3 different doctors tell you 3 different things. So as I thought about all of that, what I kept asking myself was, imagine I lived in a poor urban neighborhood. Who was going to come and help me? We need to identify those people and we need to get them there. That's part of the health literacy task. What if I lived in a rural area? Would I have internet access? Could I sign onto my patient portal? What if I was doing telehealth from a rural area or anywhere and my data plan didn't give me enough time in order to actually have a telehealth appointment? Or what if I were an immigrant and couldn't find a doctor that actually spoke my language? So if we don't address health literacy and the other related issues, we'll never get to a place where we have equal opportunities to live our healthiest lives and contribute to our families and communities. So I really want to thank Dr. Bauer and the others for the opportunity to be here, and I look forward to questions when we get to that time. Thank you.
Thank you so much, Lenny, for really giving us that background on how we got to this moment now. So my task is to just explain a little bit about sort of why we are pursued this hub approach. I won't take too long because I know you all want to hear from the chairman and you want to hear about the sausage making. So we'll get to the sausage making in just a minute. But just so you understand how the Horowitz Center is approaching this and why policy is an integral part of how we do health literacy work is because we use the socio-ecological framework for the work that we do. So we work at all these levels with all the projects that we do. Not every project has every piece to it, but overall, our projects add up to touching every point within this model. So the Consumer Health Information Hub that we're talking about in this session represents really a mix of organizational, community, and policy, right? Because the policy is now in place, but we've got to put it into practice by working with communities and organizations. We're also, as you heard in our discussion with Alice Horowitz, very much grounded in healthy people, because that gives us a national framework. It gives us benchmarks, right? It's a place that already takes this global approach to health literacy and doesn't just put all the responsibility on the individual, as you've already heard from several of our speakers. So what is this hub that we keep referring to? So it is a new initiative that moved from bill to law in the 2022 Maryland legislative session. The purpose is to promote and ensure public access to accurate, consistent, evidence-based plain language information and preferred languages. So that is text from the law. It refers to plain language in public communications about health, health insurance, and safety. And it was intentionally designed to mirror what is in the Federal Plain Writing Act. So the hub, which is going to be housed here at the Horowitz Center, our task is to work with state and local government agencies, health systems, nonprofit and community organizations. Those are the groups that are called out in the law, but obviously there are many others that the hub could end up working with over time. So some of the products that the hub is supposed to work on are health literacy criteria, certifications for doing health literacy practices, and what are those best practices. They're supposed to provide recommendations to the hub is supposed to provide recommendations to all those groups on the previous slide, as well as to the Maryland legislature. We're supposed to provide training and educational sessions to all those groups, create templates and model language, and of course, issue reports. So an annual report to the chairman's committee and to the legislature at large. So with that, that's a very quick tour through the hub's responsibilities. And now I'd like to turn it over to Chairman Pena-Melnick to talk a little bit about her perspective on health literacy and health equity, and how do you legislate something like this, given that landscape that Lenny talked about. So Chairman Pena-Melnick.
Thank you, Cynthia. It is really an honor and a blessing to be with you today. Everyone needs a Cynthia and a Lenny in their states because they are really very passionate and committed advocates. And we couldn't have done this work without this bill, without the work that you have done on health equity in the state of Maryland. So I have a lot of respect for both of you. So thank you. As an immigrant born in the Dominican Republic, I understand the challenges of assessing healthcare in this country. When I was only 8 years old, I would help my mom, who spoke Spanish, understand letters and forms. Imagine my 8-year-old self trying to understand the complex language used in those forms. It was overwhelming. This is why I'm so passionate about health equity. And I know that health literacy is a root cause of inequitable healthcare access. So how did this bill come about? Well, health literacy is both a personal issue of finding and using health information and an organizational issue of whether healthcare providers, health departments, and other entities make it easy or difficult for people to find and use the information. As I'm sure most of us have experienced, service providers may be well-intentioned, but the information they share is often dense and complicated. You heard from Lenny, an educated woman who has access to people who have access to money, and it was still overwhelming. Imagine someone that lacks the education, that lacks the language, how do they manage when they get a diagnosis of cancer or any other illness? It is overwhelming. It is unfair for them not to have the same access that Lenny has. So accurate, consistent, evidence-based, plain language information that is culturally and linguistically appropriate is an important access to provide good healthcare service. Importantly, this issue is not related to reading skills. Health literacy affects us all. We need to ensure that patients are able to understand all health material so that they do not misinterpret information that could lead to devastating consequences. As you heard from Lenny, House Bill 1082 requires state and local agencies to use plain language in public communications about health insurance, safety, and social services benefits. The Horowitz Center serves as a consumer health information hub to ensure that individuals have access to accurate information that they can understand. This is so important. Ensuring that health information and services are accessible and understandable by all benefits individuals, their providers, hospitals, and everyone involved in healthcare. So how did we, come to this point in time? I'm going to discuss with you the work that we have done and how I think that helped. So achieving health equity, as I said, requires focus and ongoing efforts to address injustices, overcome obstacles to health and healthcare, and eliminate preventable health disparities. Focusing, I believe, on health equity in the legislature, and there are 188 of us, 141 in the House, 47 in the Senate, a total of 188 policymakers that need to understand this issue. I had to convince 71 of them in the House, and I had to convince the majority in the Senate, 24 of them, in order to pass this bill, and then the governor to sign it into law. So how was I able to convince them? In a very humble way. I did not do this by myself. It took Cynthia, it took Lenny to come with their experiences and many other advocates. But the pandemic did help. So in Maryland, at the height of the pandemic, the county with the highest number of COVID-19 cases in the entire state of Maryland was gorgeous Prince George's County. We have 23 counties in Baltimore City, 24 jurisdictions. And why was it Prince George's County? Because Prince George's County is the county where it has, most of the people are Black. The majority of the citizens are Black. Then the zip code in the entire state of Maryland at the height of COVID, with the highest number of COVID-19 cases, was 20783. Who lives there, you may ask? The immigrant community, the Latino community, the African community. So that was not a coincidence. It is because of those social determinants of health, right? The way we live. I was helping people, they were living 9, 10 of them in an apartment. I was doing food distribution. It is the lack of education, the lack of transportation, the lack of money. That is the reason why Black and brown people were affected. So I put in a bill, House Bill 28 in 2021, that basically require evidence-based implicit bias training for all healthcare professionals that were looking to renew their license in Maryland. That is really important. It is very important, especially when you look at the rate of maternal health in Maryland. So I also put in a bill, House Bill 78, that created the Maryland Commission on Health Equity, the Shirley Nathan Peeling Health Equity Act. And this commission is tasked with deploying a health equity framework that will examine racial, ethnic, cultural, and socioeconomic disparities through a health equity lens. And what it does is it says the following. In Maryland, we have about 24 cabinet members that belong to the governor's cabinet members. They're our secretaries, right? And it actually requires them to come together 4 times a year to meet and discuss these issues and to create a health equity framework for each of their department. And it also requires them to work with our Health Information Exchange, Vaccinated Exchange, CRISP in Maryland, to be able to use the data to guide our policy, right? Because we have to trust the science. In addition, and the commission does not have a sunset, it is permanent in state government. This is really important. What I also did was that during COVID, I found myself getting all these phone calls from my constituents that needed help, that didn't speak English. And I found that there was no centralized statewide office to help them. So I put in House Bill 15 that creates the Governor Office of Immigrant Affairs. And this centralized statewide office plays a significant role in educating the immigrant population about available services and creating coalitions of organizations dedicated to immigrants. And the hub will be part of that. I also put in House Bill 123, which preserves access to telehealth services in Maryland, which is so important. I found that we needed to introduce those bills in order to come together to provide better overall care and improve the health outcomes for all Marylanders, especially those that have been the most overlooked in our society, those that live in the shadows, right? We need providers to take a culturally humble approach to care and meet people where they are, not where they're expected to be. This is why the hub is so important, right? By providing a framework for health equity and making it a familiar topic for legislators to understand and to make them feel comfortable, right? This is why the Horowitz hub was able to come to fruition. The hub's approach advances health equity by ensuring that Maryland residents of all backgrounds have access to the information and care they need, regardless of language, immigration status, education, socioeconomic status, or race, ethnicity. All individuals have the right to have a happy and healthy life. I really believe this. Therefore, all individuals have the right to information that will help them achieve what Lenny wanted, right? To be able to understand her care and to have the best outcome. That is the reasoning behind House Bill 1082, because it ensures that everyone can have access and understand health-related materials that can often be so complicated. I believe that the successes we have had here can easily be replicated in other states. I see that many of you are from other states and other countries. So I hope that you replicate this. The goal with this bill was to create a consumer health information hub to support state and local agencies in Maryland and not to tie their hands. To get this bill passed, it was difficult. I met with various state and local stakeholders. I firmly believe that sometimes you have to shame people to do what's right. You shame people to do what's right by using the data. Data is so important. You know, you have to believe the science. To create real and lasting changes, we all have to come together. By listening to the concerns of others, when I had these meetings, we were able to adopt amendments resulting in overwhelming support for this bill. We kept an open mind. We compromised, right? We try to remember what the goal was. And the goal here was a health hub. The goal was a stronger health literacy infrastructure, which is the best interest of all these agencies and the Marylanders they cater to make it easier for them. Our work on House Bill 1082 was a great example of the interaction between public health and policy. For so long, we have underfunded public health. And COVID taught us that we needed to shore up the public health system. And the hub will help us do that. Legislators can present health literacy as a key component of achieving health equity and promoting accessible patient-centered health systems for their constituents. we learned that there was a great need to solve this problem. And I believe that we received broad support for this legislation because we proved it, because we used the data, because we made it simple for the legislature to understand the need, that a consumer health information hub is a great tool in the arsenal for increasing health equity in all states. It will save money in the end if people can understand the language, if they can understand their care, if we can make it easier for them. So that is why I am so proud to have worked with Lenny and Cynthia and the Horowitz Center and many other advocates to make sure that House Bill 1082 passed. And I hope that other states replicate it, because it's simply the right thing to do and it will help everyone. So thank you for being with me today. I look forward to your questions.
Great, thank you so much, Chairman. And she's being very modest in, talking about the support. She was able to rally the support of all the major groups in the state. And you can go, so at the end of the slide set, which will be posted, it's a link to the legislative page for this bill. And there are all the letters of support, the written testimony that organizations provided are listed there. And you can see that this, as she said, the support for this bill was very widespread, and really got everybody in the state lined up. I don't think there were any major groups that were not in support of this bill, and that's an amazing feat. So thank you so much, Chairman, for corralling the cats and getting them into the same place.
Well, it was worth it. We have to, I had a colleague that used to say that the money should follow the policy, not the policy should follow the money. And the state needed to put some money into this. So we actually, for the next 4 years, allocated $350,000 to the center to do this work. And it's not enough, we needed more, but it's about compromise, right?
Right.
And we can always come back when we show that it works, and I know it works, and the difference that it has made and how it has saved money. So, thank you for your advocacy.
Yeah, so now I got to make it work. Right?
You will make it work.
Yes, so please use the Q&A function. So chat is just for chatting amongst yourselves, but if you have questions for the panelists, please use the Q&A function. I did see there was a question there about technology, but I'm not sure that that pertains to this panel. So I'm going to go, there's a question that just came up. How can organizations be involved in the hub? So I can certainly give my thoughts about that, but I would welcome the other panelists' thoughts. So my vision of how the hub is going to work is we're going to have a y'all come sort of philosophy about this, and that there's going to be a role for the organizations like the state agencies that have specific responsibilities, like legislative responsibilities, that there'll have to be some work with those because they're named in the law, but also because they get funding and have missions and responsibilities that we'll have to intersect with. But then there's also going to be a really important community piece to make sure that we get the perspectives of all of the parts of Maryland. So you heard the chairman say that there was one county, in fact, the zip code that she called out is my zip code, was the most greatly affected by COVID. But we know that COVID wasn't only in that county, in that zip code, it was all over the state, but it had a differential impact. And so our job is going to be to build a network across the state that pulls in all those 24 jurisdictions that the state apparatus is responsible for. So I don't know, Chairman or Lenny, do you want to say anything more about the organizational piece of this?
Yeah, sure. So, you can work with the hub. The language in the bill on page 4 of the bill says that the hub doesn't say may, shall, which is mandatory. It says here, protect and promote public health by engaging with state and local government agencies, health systems, nonprofit and community-based organizations, and other entities to carry out the hub's purpose and duties under the subtitle. So, you are welcome to work with the hub. The hub has to also create these templates that people can use and messages. You know, you can help shape that as well. So I'm speaking for Cynthia, but I'm pretty sure that your organization will be welcome in their tent.
Yes, we are definitely a big 10 group. So Lenny, any thoughts about that?
Yeah, I just to go back to what I was saying about the Commission on Health Equity and what the policy group is looking at, which is in the three of the domains of the social determinants of health, the healthcare system, the community and consumer engagement, and education. So as the hub pulls people in, as I know Cynthia is going to do, to have conversations about that, I think that it will provide an opportunity for organizations within those arenas to think about how they can intersect with the hub, and the hub in its turn can look outward. If I could, Cynthia, can I just go back and make a point about how other states, some of the opportunities that I've seen in other states to focus on health literacy as advocates? Can I?
Yeah, just a little bit. We have like 5 questions. So if you could just, brief, that would be great.
Yeah, so again, to the commission, we've been doing some research on what's happening in other states on health equity framework. And just to, in Massachusetts, there is a, the task force that was set up post-COVID has developed a health equity practice and style guide. So advocates in Massachusetts ought to be looking at that style guide, who's doing the work, and how can they leverage that to get more of a discussion of health literacy on the table. And in Washington State, there's a great community engagement guide. Again, that's a platform, the people working on that at the state level to get in those doors and put health literacy on the table. I think you've got some, remember, seize the opportunity. Those just 2 examples of opportunities to get health literacy being discussed.
So Lenny, if you have links to those things, could you put them in chat for people?
Okay,
or send them to us and we'll put that, I can add them to the slides at the end when they get
that'd be
posted.
good. There's some other, yeah.
Okay, great. So Chairman, you're already in demand. Somebody is asking, can they have your contact information? So if you are willing to put your email address in the chat, that would be great.
Yeah, my staff, my wonderful team is on this webinar, and they already actually provided it in the chat. So we welcome your calls.
Excellent.
Thank you.
So we have a question. How are individual health professions incorporated into programs? So I'm not really sure which programs you're talking about, if it's the hub programs, but I think you've heard that we see health professionals, certainly the chairman referenced the bill on implicit bias training. There are actually some prior laws here in Maryland that recommend health literacy and cultural competence training. So there are a number of pieces in place here in Maryland about sort of training and educational pieces for the health profession. So if you're looking for something else, if you could just elaborate on that question in the Q&A, and we'll try and get to that. Next question. I live in Prince George's County. I've lived in Prince George's County all my life. What can I do to help increase health literacy in my community? I don't think there are many resources in Prince George's. So I will say that every county in Maryland, this is at the direction of the Maryland Department of Health, has a health coalition that the county health department organizes, but it also has strong community involvement. I would encourage you to get involved in the Prince George's Healthcare Action Coalition, because that is where a lot of the local work is happening. But Lenny, as an advocate, what would you suggest to this person who wants to get involved in health literacy at the community level?
So again, I would look at what's happening with your local health department as an opportunity. And I think you have to reach out to the other organizations, consumer-based organizations in the state. Maryland, because of its local health improvement coalitions, which are part of the state health planning process, has leveraged some of this and made it, I would argue, a little bit easier to find these groups. But for our organization, when we were alive and breathing, it was really a process of 10 years or more to find the resources. But the groups in your communities who are working with immigrant populations are one place to go as well.
Yeah, so the Prince George's Healthcare Action Coalition is one of those local health improvement coalitions that Lenny just mentioned. Every county in Maryland has this local health improvement coalition, and you can contact your local health department to find out more about that.
There's, if I may, there's also a
ahead.
health equity work group in Prince George's County, and I
Exactly.
believe it's probably through that coalition. And I will put the email in the chat room about it's called. It's actually on the health equity work group contact. I'm going to put it right here, and you can give them a call.
Great, thank you.
You're welcome.
Our next question is, are there consequences for not getting information in plain language? So I think, Lenny, you kind of started to speak to that, and Chairman, you did as well. So if you want to elaborate on that anymore. And what are the teeth for ensuring engagement? In other words, what are the carrots and the sticks to get compliance with using plain language?
So, yeah, I think the question is more for the, not from the personal perspective, because from the personal perspective, if you can't sort through the different recommendations on medications from 3 doctors, you're gonna, you need an advocate who knows what they're talking about in addition to you. But in thinking about the legislation, I know Chairman Pena-Melnick, we talked about the challenge of not putting too many sticks in there because of the challenges of not getting support of different organizations. So to me, there's a careful balance there that the chairman could really, I would think, address.
It's, you don't want to be punitive, right? Because then I can't get the bill through. So first we have to lay the foundation and create this hub. And the hub will come up with recommendations to state, nonprofits, different agencies. And then later on, we'll see how we can have some of those sticks. I know that there are federal laws that require certain communication, like translation, and certain when you have a certain percentage of your population they speak another language in your jurisdiction. So we can look at that. But for now, we basically wanted to create the hub and get the money for it so that we can show the need and how it can really improve lives. So if I had any language in the bill that would fine people or, that was punitive, it wasn't going to pass. So when you legislate, you have to come to the table and try to compromise and keep your eye on the ball. And that was one of the that was a compromise that I decided I wasn't going to do anything punitive in the bill at this time.
Yeah, and just if I could, just one quick thing. I mean, there's a reality to the fact that the more informed the consumer is, the better decisions they make. That's good for them, but it also lowers the cost to the healthcare system. And making that argument to connecting health literacy to better outcomes to lower costs is a really tough one. I mean, we try to make that argument for 10 years or more, but I think there's a validity to it that we could all do a better job on. That's just advocates' perspective.
And just to call out one program that I know IHA, Michael Villaire's organization, has been involved with, is there's a group out at UCLA that's been doing a project for a number of years with Head Start, and with Head Start parents, with Head Start teachers, Head Start kids, and using IHA's materials about what to do when your child gets sick to help parents understand that they have options besides just going to an emergency department. That's a very, that's a very specific thing, right? Getting people to think about what options do you have besides going to an emergency department, which is the most costly option, right? That most people have. So if you can get people to just even make that little shift, can have huge cost consequences. And so I think, to what you're hearing is that there are positive stories that we can tell that hopefully will motivate people to get on board with this. And hopefully the sticks will have to be few to none, right? I mean, maybe they'll have to emerge, but we need more information first before the chairman said, like, we bring out the sticks.
You get more with honey than you do with vinegar.
Someone told me that a long time ago. So there was a question about the percent of the population, BIPOC communities facing this health disparity. I assume people mean low health literacy. And then how do you support the incarcerated? So there's nothing specific in this bill that speaks to working with incarcerated populations, but there's nothing that precludes that either. So I think that's certainly an option. And in terms of data, the only national data that we have on adult health literacy skills was collected by the U.S. Department of Education back in 2003 and published in 2006. And that's been a real missing piece at the federal level, is to have data collection mechanisms in place to have national data on this. So there are individual states that have tried to do this through their behavioral risk factor surveillance system survey. And I actually saw that Maryland had put health literacy on its next BRFSS collection schedule. So I think, you can look at the state level, but that's something that you could work at. I wouldn't hold my breath for the federal level, but that's definitely something you can work on at the state level. We're down to our last few minutes here, and I just want to call out, because I believe Mario, who is tech support from IHA, there's a question about getting a transcript of the chat because someone said they don't seem to be able to save it or copy and paste it. So if there's an answer to giving people a transcript of the chat, if someone could put that in the chat. So we're down to our last couple of minutes. I want to give our speakers, that wrap up opportunity to offer a final wrap up thought. So Lenny, one takeaway you want to make sure that our participants here today?
Sure. So I'm going to say, don't forget the 5 Ps: passion, purpose, partners, persistence, and patience. You can tell that a good legislator, Chairman Pena-Melnick, has all of those. And I would also say, don't forget occasionem carpe. I didn't get through Latin for no reason. Seize the opportunity and get yourself in the room where it happens. Don't be shy. That's not my problem, and it shouldn't be yours either. Thank you very much. I really appreciate participating today.
Great. Chairman, your final word, what's your takeaway?
Remember that just like your 5 fingers are all very different, right? You need them all for your hand to function. People in our community are all very different, right? But we also have a lot in common. And what is that? Is that we want good health. We want to be able to live a happy life. We want to provide for our family members. And it is important for all of us to have the same information, to be able to understand it, and to be able to use it so that we can have a wonderful life. And I think that this is where the hub is so important, so that people can understand the words given to them, the instructions given to them, and so that they can live their best life possible. Not just someone that is wealthy and educated, but that it would apply to everyone, no matter who you are, no matter where you come from. And that is the beauty of this hub. And I hope others are able to replicate it.
So I cannot top that inspirational message. I will just say, stay tuned. There's a lot more to come about the hub. So keep your eyes on Maryland, because we're really doing great things here. So thank you so much to the chairman, to Lenny Preston, to Maria, to Alice, and of course to my co-host, Michael Villaire. We've got lots more great programming to come the rest of today and tomorrow. I think we have like a really stellar program with lots of new innovative ideas to come over the next day and a half. So Thank you so much for joining us for our opening plenary session. Michael?
Thanks, and I guess we're going to take a short break now and a couple breakout sessions in 15 minutes. So if you want to back out of this session and then come back in to the new ones and make your selection, we'll hopefully see you then. Thanks, Cynthia, and thanks to
Yes.
the panelists. You guys
Take your
were
bio
awesome.
break and we'll see you back in a few minutes. Bye-bye.
Thanks.